Colton has to be out, so we'll try to help out and record this. Okay. So, traumatic brain injury, again, is where we'll start. Chapter 19. It is a condition that happens more than we think. It will be a significant injury to the brain, no matter how much the person recovers. So even if they are progressing, they're going to always have some form of deficit because their brain was damaged due to whatever the predating cause was for the injury. So let's look at it here. Let's go through what we know. It says a TBI is defined as an alteration in brain function or other evidence of brain pathology. Something has injured the brain, is caused by an external force. So the brain can't injure itself inside and out. Now it can hemorrhage, it can bleed. I know we can have different things going on inside of the brain, but TBI is usually caused by something causing trauma. The population is one of the most challenging with physical therapy. They are difficult to manage, not because they're impossible. They just change a lot. They could be some of the sweetest people that you've ever dealt with in your life, just kind, very affectionate, trying to help do the things that you're asking, and then in an instant they can flip, become mean, combative, aggressive. I've seen one TBI patient who had a therapist like pushed up against a wall in a threatening manner, and went from being just nice, mannerable, pleasant to like within an instant just kind of went left. So be very careful treating this population because they don't always respond normally. They have things that can go, they can go quickly from one mood or one expression to another very quickly. Okay. It says because of the multiple body systems affected by brain injury and the strong likelihood of a secondary impairment, therapists must be proficient in a variety of procedures and interventions. That makes sense. Page 860 at the top, a physical therapist or PTA, either way, working with this population must also possess strong communication and interpersonal skills, be able to react quickly and effectively to sudden changing situation, and have keen observation skills, because these things, you'll start to see them start to shift in their behavior, and you need to be ready for it. That was page 859 and page 860. Oh, shoot. I have the wrong book. That's why. Thank you. Ha! Yeah. Glad you said something. I just grabbed one of the books off my desk. It's the old text. She was like, huh? Here we go. This will make sense. Now we're on the right path. I will take it. Okay. Okay, here we go. Now, my apologies to you all. I was in the wrong book here. Okay, yes, there we go. Yeah, so there we go, 818, yes. Okay. It says the patient with a brain injury is treated across a wide continuum of care, starting from the intensive care unit. So they'll be managed originally from there, an acute care hospital. They're usually going to be transported to inpatient rehab if they can tolerate it, or a skilled nursing facility. So they just depending on their level of tolerance, they're either going to go to skilled nursing first and then to rehab, or rehab first and then they may downstep to skilled nursing. And then some of them will need long-term care facilities like nursing homes because they will not be able to live independently on their own at any point. Okay, so prevalence. TBI is the leading cause of injury-related death and disability in the U.S. So it's a huge number of people when you think about it. In 13, there were about 2.8 million people admitted to the ER or hospitalized or died as a result of TBI. It's a lot of people. Down at the bottom, where it says, in all likelihood, the numbers are probably underrepresented, even with that number that we have. So more people probably have the injury. They just weren't diagnosed with it properly from the first end. Falls are the leading cause, followed by struck by or against events, meaning like football or something struck you in the head. Sporting events where hard items can strike you in the head. Golf balls, hockey pucks, you'll see that a lot. Subdural hematomas. People get struck in the head with a hockey puck, and now they have a struck by injury or struck against injury. Then you have motor vehicle or traffic accidents after that. So a lot of those, head-on collisions, side collisions, rear end, all of those can affect it. Older adults are at a greater risk for TBI, and the reason why is they don't have type 2B muscle fibers to react quickly, so they fall a lot and they injure themselves. Followed by infants or youth from ages 0 to 4 months. And then older adolescents from 14 to 24, a little bit around the age where you first learn to drive or get a driver's license, which makes you extremely dangerous. Hospitalizations and deaths are, as a result of TBI, are most common in older adults. Motor vehicle accidents are the most common cause of moderate to severe TBI in younger adults, which decreases with age. So as you age, you become safer and do less dumb things, and you tend to have less chances of developing TBI. Falls are the most common cause for older adults. Okay. So there are a lot going on with that. Mechanism of injury. The brain damage results from an external force that causes the brain tissue to make direct contact either with an object, meaning it could be our skull itself, or something penetrating it. So like something sharp penetrating the brain. So it doesn't have to just be the skull it's making contact with. Penetration head injuries also go with that as well. Okay. Rapid acceleration is another one. Think about motor vehicle accidents where you're stopped and someone slams against you at a high rate of speed. Your body goes into a rapid acceleration and deceleration phase that can cause force or blasts from an explosion. This is usually more militaristic or military based, people being injured by IEDs. So when you see the term IED, we'll get to it. Let's tell you what it is. An IED. So if you hear that term, you don't hear it very much anymore since we're not functionally at war per se, but it's an improvised explosive device. So if you hear somebody say something, I was injured by an IED, they're saying I was injured by an improvised explosive device, a blast injury. Or these could be specific blast things where dynamite or other things are being used, gunpowder type things are being used that blow up before their time or blow up in a way that's not meant to have happen. Generally speaking, brain tissue damage can be categorized as either a primary injury that is due to direct trauma or a secondary injury that results from a cascade of biochemical, cellular, and molecular events that evolve over time due to the initial injury. Okay. So, primary TBI, we're dealing with that. It results from either brain tissue coming into contact with an object, either the skull or an external object such as a bullet or a sharp instrument that creates a penetration injury. People falling on stuff and it penetrates their head. Sharp objects falling on and it penetrates into the brain. That could be one of those type things as well. They also can have rapid acceleration, deceleration of the brain, creating cortical disruption. So rapid acceleration, deceleration. And we'll give you a name for that in just a second. Contact injuries often results in contusions, lacerations or scrapes, or cerebral hematomas, or bleeding in the brain. Okay. Common areas of focal injury are anterior parts of the temporal lobe, the frontal lobe, and lateral and inferior temporal cortexes. Acceleration and deceleration cause shear, tensile, like it's pulling, and compressive forces within the brain, which will cause diffuse axonal injury, tissue tearing, and intracerebral hemorrhage. DIA is the predominant mechanism of injury in most individuals with severe to moderate TBI. It is common in high-speed motor vehicle accidents and can be seen in sports-related TBIs. So it's a really big deal, diffuse axonal injury. Blast injuries is considered a significant injury dealing with the U.S. military. When an explosive device detonates, a transient shock wave is produced, which can cause brain damage. So, it's not like you see on TV where I can run and get out of the way of a bomb exploding. Bomb is happening, duck! And you fall and the bomb blows up and I have one or two shards landing on my back and I get up and I dust myself off and I'm fine. No, that's not what happened in real blast injuries. Real blasts create a shock wave that can injure the brain and injure vital organs at a significant distance away from where the bomb was exploded. So it's a big deal. Primary blast injuries, from the direct effect of the blast overpressure on organs. Primary blast injuries result from the direct effect of blast overpressure on organs like your brain or your heart. Secondary results from shrapnel from the bomb being hurled at you. So let's say that usually with improvised explosive devices, they will put dangerous things inside of them. So even when they blow up, if you're not in the vicinity, the shrapnel will still injure you. So they'll put in things like nails, they'll put in things like ball bearings, anything that can hurt, screws. So they'll dump in a bunch of that kind of stuff, and it turns the bomb into a projectile, like a gun. And it's shooting these things out at you when the bomb goes off, and that can injure you just as much as being too near the bomb. Okay, and then a tertiary injury occurs when the victim is flung backwards and strikes an object. So that shock wave, that blast radius, will have so much force coming from it, it can literally pick you up and hurl you in a direction and knock you up against something. Car, a house, bricks, whatever is around, it hurls you against it and it creates a brain injury. Okay. Secondary injuries. Secondary cell death occurs as a result of a chain of events that follow tissue damage in addition to secondary effects of hypoxemia, loss of oxygen, hypotension, ischemia, edema, and elevated intracranial pressure. Secondary processes develop over hours and days. We won't go crazy on all of those. Hematomas are usually classified according to their site, epidural, subdural, and intracerebral. Normal intracranial pressure is 5 to 20 millimeters of mercury. Severely increased intracranial pressure typically results in herniation of the brain, requiring emergency treatment. So, common types of herniations are uncal, central, and tonsillar. So let's kind of show you some of those, the dural layers of the brain, so that will make sense. Okay. So when you're looking at the brain, that's a good one. So below the skull, you'll have your epidural, subdural, and then, crap. Hang on, let me do this. I keep forgetting. Trying to do stuff that makes sense. I'm coming. Okay. Let's duplicate the shell. Okay, so when we look at it, we have different layers of the skull that gets down to the brain itself. So above the brain, so if this was the brain itself here, the pink portion, above that you have different layers of space that helps to protect the brain and keep it safe. So the layer that's directly, that coats the brain directly is the pia mater, and then you have the subarachnoid space right above the pia mater. Then you have the arachnoid mater, and then the dura mater above that, and then the bone of the skull. So epidural space is the space beneath the bones of the skull and the dura mater. Subdural is between the dura mater and the arachnoid mater. So, and then subarachnoid is here and there. So you don't have to know all of that. It's just good to kind of connect some of those to know where the things are. So hematomas, or swelling on the brain from an injury, is going to be classified according to the site where they happen. Either epidural, which is going to be, again, between the skull and the dura mater, usually subdural, between the dura mater and the arachnoid mater. So a lot of times when people are hit, I'll never forget, I was watching, well, you didn't see it, but they reported on ESPN, a young girl, she's about 8, she went to a hockey game with her dad, a professional hockey game, and somehow the puck went flying too high and hits the little girl in the head, and it gave her a subdural hematoma. So it was a hematoma between the dura mater and the subarachnoid space. And so the dura mater and the arachnoid mater. And the young girl spent days in the hospital, weeks, maybe months, I think probably weeks in the hospital, and I think her brain activity finally ceased, and then she ended up passing away. So injuries to these areas do happen more than we give them credit for, whether we know it or not. Okay. All right. Any questions there? So if you look at ICD-9, they have some terminology that's specific This stuff isn't per se in the book, but it's good to just know it. This is kind of new. So the first one, it actually describes the different types of injuries. You can have the closed head injury. That's when the soft tissue of the brain itself is going to be forced into contact with the skull. So you can have variations of closed head injuries, meaning nothing penetrates the brain to injure it. The injury comes, but the skull is still intact. So it's closed head injury. So you can have a mild one to severe one. Mild ones can occur after a severe neck injury without the head striking anything, like a whiplash injury. You're in a car, you're sitting at a light, you're not paying attention to what's going on behind you. Car comes up, slams into the back of you, throws the head forward rapidly, throws the head back rapidly, slams you forward and backwards really quickly, shifting the brain, and that can cause a mild closed head injury not because your head slammed into anything, you didn't hit the steering wheel or the windshield, but just that rapid flexion extension caused you to now have a closed head injury. Severe results from significant bruising and bleeding within the brain. So this is now the injury to the head is so severe, it's starting to cause cerebral bleeding. So we're starting to bleed into these certain areas, and now it's starting to become really dangerous. You can also have primary brain damage. It can be from either diffuse axonal injury. We'll show you what that is. A focal injury, meaning something happens right there at the site, so it's focal. Say you get, you're a boxer, you get punched in the head right there in the temporal lobe. That's a focal injury, focal primary brain damage. Coup contra coup is another one. We'll show you that one, or closed or open. Closed head injury, again, is going to be an injury to the head where there's nothing penetrating. Open head injury is going to be where there is a penetration injury, where something actually penetrates the head. So you see all these crazy videos with people falling on poles or sharp items, and it penetrates the brain, and they're having to be taken to the hospital to have it removed. Those are open head injuries. Contra coup, let me show you that. That's kind of what you'll see. That's when the head will strike something in one direction, and it moves the brain in a rapid acceleration in one direction. The brain then slams against the skull and then rapidly accelerates in the other direction. So let's say this is a wall right here, or something, steering wheel, a wall, whatever you want it to be. The person is going full speed into it. Wham, the head slams into whatever it is. The brain moves forward, slams against the anterior aspect of the skull, and then in a secondary injury, because it can't slow itself down, it then slams itself against the back of the skull, creating two different sites of damage. So I have what's called coup contra coup injury. So I know it looks like coop, but it's coup.
So what's the difference between that and concussion?
Concussions are very similar to this, but usually it's not the contra coup injury, it's just a one direction injury with a concussion. Yes, sir.
Does that necessarily have to be just the front and back of the brain, or can that happen side to side?
Lateral, you can get a coup contra coup lateral. You can get a coup contra coup lateral. So understand your brain isn't as wide as your skull. So the brain is actually suspended with all of the different protective layers around it, and it's suspended in cerebrospinal fluid. So the brain has all this fluid around it to protect it in case you do something crazy, so that the brain doesn't injure itself. Let's say you are, running and not paying attention, and all of a sudden you look up and there's a wall, and wham, you hit the wall and you fall down, and you have a headache, but you don't have a brain injury because the brain is suspended in the cerebrospinal fluid, which protects it. It's only when we're moving at such a rapid pace that the cerebrospinal fluid can't slow the brain's speed down, that the brain slams against the skull and it creates damage. Does that make sense? So just general stuff. If you fall today and bump your head, chances are you're not going to end up with a brain injury. Anybody fell out of the bed recently? Nobody? I don't have kids. Okay, that's no. It happens. They come and wake you up in the middle of the night, scare the crap out of you. Fall out of the bed. Like, God almighty, kids are gonna kill me. So, anybody fallen recently? Nobody? Y'all are too healthy. Sir? I don't have a measurement on it. I mean, it's enough that you can sustain injuries to the head without having damage with very short amounts of doing it. So you think of boxers, most boxers aren't injured because they're in one fight. It's multiple years of being banged around in the head where the brain is slamming into the wall, throwing the brain into a tizzy, and now that gives us these brain injuries. So it's enough that it should sustain you no matter if it's basic injuries, it should sustain you. It's multiple repeated or severe injury.
So that's the basic scenario with concussions over time. Football players.
Right. So when they are what's the name of that thing? Where they're starting to look at it now. Which one? CTE. There we go. Thank you. My brain took the day off. CTE. So when they're looking at CTE, it's repetitive incidences of rapid injuries to the brain where the brain has been slammed against the different cortices of the brain that injures you and that causes brain damage. So it's usually not a one-time incident. It's repeated injuries over time. Now, you can one-time injury it, but it has to be rapid, multiple, like the Tua thing. I think the first time he was hit, he was concussed. He should have not come back in the game, should have been off for at least 2 to 3 games. The second hit was a sequelae of that, and that's the reason he ended up with the brain stem injury, where the arms were in that decorticate posture. So you can injure it pretty bad. So coup contra coup is usually the brain slamming against something and then the head slamming against something, causing the brain to slam against the skull with such rapid force that it then rebounds and bangs against the opposite side of the skull, damaging it on both areas of the brain. So instead of just having a frontal brain injury, I also have frontal and posterior brain injury or ventral brain injuries because of coup contra coup. Okay. Secondary can be due to things like hypoxia, not enough oxygen, ischemia, same way, not enough blood flow. So hypoxia is an oxygen deficit. Ischemia is due to a lack of blood flow. So you can have enough blood flow going, you can have blood flow going to the brain and not have enough oxygen saturation in it and still have a hypoxic brain injury where blood flow is circulating in my brain, the blood hadn't stopped, but it's not enough oxygenated blood going to it, so now the brain is starving for oxygen, even though there's still a pulse. Brain is fluid, blood is still circulating, there's a pulse, but I'm not getting enough blood flow to it. Ischemia is when we stop blood flow to an area. Intracranial pressure, this could be due to swelling in the brain from infection. Meningitis is one of the things that comes to mind with that, where you have an inflammation of the meninges, the different layers of the brain, dura pia mater, arachnoid mater, the meninges begin to become inflamed, and now you're getting swelling of the brain. You're getting swelling around the brain, causing intracranial pressure. And then brain herniation, that's when you're starting to get swelling inside of the brain, either due to injury or whatever, and now the brain herniates through the foramen magnum. So that's a secondary injury. It's not caused because the brain slams against something. It's caused as a secondary event to something going on. Concussions. So this one is good. This is an added slide, so it's not in your book per se, but it's good to know. So what are concussions? Concussions are loss of consciousness, either temporary or permanent, resulting from an injury or blow to the head, impairing function to the reticular activating system. Remember, we talked about that, I think, in chapter 5, where we talked about reticular activating system and its importance to helping with cycles dealing with sleep and wake. So if we damage that, then it throws off our sleep-wake cycles. Injuries to this reticular activating system can affect some important things. Heart rate is one, respiration rate, and it can also affect, what is that? Should it be PT? That's something I should know. Heart rate, respiration rate. It'll come back to me what the PT word is. Not PT as in therapy. It's something else specific. Mild concussions, only momentary loss of consciousness or confusion. So you'll see people, boxers have this all the time. If you watch boxing, someone gets knocked out. They have a mild concussive syndrome. They wake up. It's a momentary loss of consciousness. You see someone, their knockout reflex is triggered. They go bang, bang, they get hit. Their body goes limp. It's a true knockout when there is no protective responses. Protective responses mean if I punch you in the face randomly, you were walking toward me and I rabbit punch you in the face, pow! And now it knocks you off balance and you're falling backwards. The first thing you're going to do as you're falling backwards is do what? Try to catch yourself. You're going to put your arms out. It's called protection extension backwards. It's a reflex that integrates as a baby. You're going to try to protect yourself from the fall because you know you're getting ready to hit the ground. You know it's a true loss of consciousness when the person has no protective responses. When they get hit so hard that when they're going down, they either buckle on their knees or they just fall flat to the ground. They don't put their arms out. They don't try to protect themselves going forward. They don't try to protect themselves going to the side or going to the back. They just literally fall out. That's a wonderful example of a type of concussion. And it doesn't always have to go to that level, but just a temporary loss of consciousness where you no longer remember why you're where you are. It's like, how did I end up here? You just got knocked out. Oh, crap. What happened?
And they're not coming up.
Oh, yeah. I mean, they'll be fine after a few seconds. Once reintegration happens, usually it's pretty quick. They usually wake them up from that. Smelling sauce. If you're dealing with boxing, they have a strong odor. Smelling sauce that helps to re-stimulate everything and get them awakened. You see it all the time in sports where football players will get these. They'll be concussed and they'll tell you, I don't even remember what happened after the hit, or someone landing on their head. Basketball, somebody undercut somebody's legs and they're just laying there. Like, I don't even remember what happened. So you see these all the time. Concussions happen. This can happen, like I say, even with car accidents. Slam your head against a windshield. It can concuss you. So it will happen. Mild concussions, the patient may exhibit retrograde amnesia, meaning they don't remember what happened just right before whatever happened that caused the concussion. So they may not be able to recall exactly what happened. You may talk to someone who's like, do you remember what happened? I don't remember anything about right before it. I just remember, and they may give you events leading up to it, but they have retrograde amnesia up to that point. Classical ones are moderate in severity with loss of consciousness, and it mostly reverses after 24 hours. So these are ones that are much more severe, and they can have retro and post-traumatic amnesia, meaning events that happen right after the event. So they don't remember, not only do they not remember exactly what led to it, they may not even remember the sequelae or the rest of the event even right after. So they can't even recall to you. It's like, you ended up, how did I get here? They're in the hospital bed. Go, how did I get here? What happened? They have no clue. So they've had post-traumatic amnesia. And then the severe one is loss of consciousness longer than 24 hours. These are people who have what's called, is usually associated with diffuse axonal injury. So let's talk about diffuse axonal injury. Show you a little bit about that.
Emotional and physical health. The new Sleep Number Climate 360 smart bed is the only smart bed in the world.
Today's topic is diffuse axonal injury, or DAI. A diffuse axonal injury is a traumatic brain injury in which lesions are produced. Is diffuse axonal injury, or DAI. A diffuse axonal injury is a traumatic brain injury in which lesions are produced in the white matter over a widespread area. Brain tissue is divided into cortical, or tissue found on the surface, and subcortical, or tissues found in the deeper part of the brain. White matter is a subcortical tissue. It is found in the deeper tissue of the brain. It is made up of the axon, or nerve fibers, that are majorly surrounded by a covering or sheath called myelin. This myelin is white in color, which is why the myelin-covered axons are called white matter. The neurological impulses carried by the axons of white matter enable the body to function properly and are widespread within the brain. During the axonal injury, the axons that are damaged spread over a large area and not just one isolated spot. This is why diffuse is used with this type of injury. Diffuse axonal injury mostly affects white matter in areas such as the brainstem, the corpus callosum, and the cerebral hemisphere. Other common locations include the white matter in the cerebral cortex, basal ganglia, and thalamus. It is one of the most common and severe traumatic brain injuries, as it affects numerous portions of the brain and is life-threatening. Most people who suffer a severe injury are left in a coma, and about 90% of patients never regain their consciousness. Those who do wake up are often left significantly impaired and even disabled. A person that suffers diffuse axonal injury may have mental and physical limitations and may often depend on others to perform basic tasks. Causes. A diffuse axonal injury is as a result of acceleration and deceleration that triggers the brain to move backward and forward swiftly inside the skull. This can occur due to car accidents or motorcycle accidents, falls, especially those that cause rapid whipping motion of the head, violent attack, sporting injuries, shaken baby syndrome. Symptoms. Patients with severe DAI may experience loss of consciousness. This is the prevailing symptom of the condition. In mild DAI, patient may have a concussive disorder associated with a headache, as well as loss of balance, drowsiness, disorientation or confusion, nausea, and vomiting. Diagnosis and treatment. Diagnosis. Because damage to the brain is microscopic and not macroscopic, diagnosing DAI with CT scan may be difficult. However, a well-established MRI method called diffusion tensor imaging is used. This procedure provides a detailed view of the brain and allows mapping of the orientation of the white matter tracts. Treatment. Reducing any swelling in the brain is the first course of action needed in the case of DAI. If this is delayed, it can cause further damage. In some cases, steroids or anti-inflammatory drugs will be given to reduce the swelling. Severe traumatic injury has a likelihood of a vegetative state or death. In mild to moderate cases, rehabilitation is possible. Depending on the individual, recovery program can include speech therapy, counseling, adaptive equipment training, physical therapy, occupational therapy, recreational therapy. The Traumatic Brain Recovery Program involves a team of doctors, nurses, and specialists, including physical, speech, occupational, and recreational therapists. Complete recovery may be possible in very mild cases. Thank you for watching our video. Please do not forget to like and share the video. Also, please subscribe to the channel to stay updated on our latest videos.
BetterHelp is customized online therapy that offers phone, video.
Usually, if they're in these severely concussed situations, very little are we going to be doing. Usually, when we're consulted as PT, our goal is going to be. Okay, here we go. Usually, when we're consulted as PT for diffuse axonal, our role is going to be very small in their lives. We'll probably be teaching family members or caregivers or nursing how to perform passive range of motion activities, and they'll do a maintenance program. We'll discharge them to maintenance because the family member will have to work on, the family member or nursing will be working on passive range of motion, trying to keep the joints mobile to keep them from becoming contracted. So there's not a lot we're doing with these severe diffuse axonal injuries. Okay, so sequelae of traumatic events. Traumatic brain injury is associated with a wide spectrum of all of those: activity limitation, participation restrictions, and diminished quality of life. We won't go through that box there. So 820, although physical therapy interventions primarily address physical limitations related to mobility, the cognitive and behavioral changes associated are often more disabling because they're going to have a lot of cognitive and behavioral issues. Again, they can go from 0 to 100 from left to right. I mean, nice, kind, to combative, angry, yelling. I've seen some people who have personality defects. They were the nicest, kindest person. I remember one lady, she was like, my husband never used a bad word, and all the time I've known him, it was like, I think they've been married almost 20 years. And he had, I want to say it may have been a car accident, like a bike on car accident. And it shifted his personality pretty instant. And man, he was combative. He would come in, he knew every 4-letter word that you can call out. And some I didn't even know existed. Like, whew, that's a whole nother level of cursing. So, and I mean, but it was a personality defect. It wasn't who he was, it affected his personality due to the injury. So those can be really interesting to manage. Okay. Body structure function, let's see here. Let's do this. Let's take a break on that one. We'll give you a few minutes off, and then we'll come back and walk through this. Walk through some of the rest of this. Back on it. Okay. So, all righty. So let's talk about the sequelae or the resulting issues. Sequelae is just meaning resulting issues that happen because of traumatic brain. So I had traumatic brain. Now, what are the resulting issues that happen? So, body structure and function. Yeah. Okay. So individuals with TBI commonly exhibit impaired motor function because their motor area is usually damaged. Upper extremity and lower extremity paresis, impaired coordination, impaired posture, abnormal tone, and abnormal gait are usually seen and may be lifelong impairments. Abnormal involuntary movements such as tremors or chorea and dystonic movements are less common. So those are usually, tremors. You're thinking about cerebellum, basal ganglia. Those aren't usually, they're really deep areas of the brain. So they're usually not damaged as much. It's really, really hard to damage a deep area of the brain. Okay. Cognitive. Cognition is the mental process of knowing and applying information. Because of it, it is difficult to localize the exact structures responsible for it. However, many functions are controlled by the frontal lobe. Personality is controlled by your frontal lobe, meaning the front part of your brain. Personality is, cognition is as well. So those are important. It includes complex neural processing like arousal, attention, concentration, memory, learning, and executive function. Executive function is planning, cognitive flexibility, initiation, and self-generation. Response inhibition, meaning I'm able to control myself and not respond belligerently or in a way that's outside of what's normal. And ordering and sequencing, serial ordering and sequencing are all things that deal with cognition or executive function. Soon after injuries, patients often present with disorders of consciousness. Between 10 to 15% of them are going to be discharged from the acute care hospital in a vegetative state. And we've talked about what vegetative state is. And the prevalence of them will be in a minimal conscious state, which is slightly greater than that of a vegetative state. So there'll be one step up. So we'll talk about that Alexander levels of consciousness or Alexander levels in a few minutes. Well, probably next time we meet. Soon after, patients often, we talked about it. The term unresponsive wakefulness has been proposed to be used instead of vegetative state. However, it's not gaining traction at all. With this, it can be difficult to distinguish this from disordered arousal. Many injuries begin with coma, where the arousal state is not functioning. Their eyes will be closed, there's no sleep-wake cycle, and the patient is going to be on a vent, meaning they can't breathe on their own. Breathing and respiration won't be self-controlled, it'll need a vent. There's no auditory or visual function and no cognitive or communication function. There's going to be abnormal motor and postural reflexes may be present. The corticate decerebral posture depending on the patient. Coma is usually not permanent. Patients may become brain dead and enter a vegetative or minimally conscious state or go on to full recovery. So it just depends. So when a person is declared brain dead, that means that the upper centers of the brain, the cerebrum, the part that deals with motor function, movement, processing sensory, vision, all of those things no longer function. So we don't have the abilities to process with our cerebrum. The only thing that's keeping us alive is our brain stem, which deals with cranial nerve 10, which helps with breathing. Vagus nerve helps with breathing. So we're breathing, but there are no sleep-wake cycles. They don't have function. They can't move. They can't actively participate. In a vegetative state, there is disassociation or a break between wakefulness and awareness. The higher centers of the CNS are not integrated with the brainstem. It's kind of what we said. The brainstem manages basic cardiac functions, basic respiratory, and other vegetative functions, and the patient may be able to be weaned off the vent. So once the brainstem is back functioning, they'll be able to do cardiac and respiratory things, and they won't need the vent to breathe for them. Sleep-wake cycles are now maybe present. The eyes may open, and through awareness of even though awareness of surroundings are absent. Reflexive smiling or crying may be present. A withdrawal response to noxious stimuli may be present. Although they're in a vegetative state, they may appear to have purposeful movement. They are really just reflex responses to external stimuli. So it'll look like if you poke their foot with a needle, it'll look like they're drawing up, but it's really just the reflex of being stimulated causes it to draw. It's not them actively doing it. Patients in permanent vegetative states have no meaningful motor or cognitive function and a complete absence of awareness of self and the environment for greater than 1 year after the traumatic brain injury and greater than 3 months with the anoxic brain injury. So that's good to remember. If they enter a minimally conscious state, then there's some evidence of self and environment. Not a whole lot, but there may be some. Commonly used terms to describe other altered levels of consciousness are words like stupor or attendant. Neurobehavioral, they can exhibit profound behavioral changes as they progress. These can be closely linked to cognitive impairments and are often more debilitating in the long run than the physical stuff. Common things you'll see, low frustration tolerance. They are highly agitated. Disinhibition, meaning they don't know how to inhibit their behavior. So right now you have what's called inhibited behavior. Even though you may get frustrated, let's say you don't make the grade you want on the test, you have inhibition, you sit in your seat, you go, oh man, it's a sad day, I didn't do what I want. You don't jump up, run around screaming, throwing over tables, kicking over chairs, bursting out windows, running down the thing, pulling off your clothes, running around the baseball field naked. You have inhibition. Thank God. Inhibition. People with TBIs don't or have very little, and that makes them dangerous. Apathy, emotional liability, mental inflexibility, meaning they're very concrete, usually in their thinking. They don't have the abilities to see nuances of speech or things that you're saying. They can be physical and verbally aggressive. I talked to you about patients who've been both of those. Impulsivity, they're highly impulsive. Just like some of the brain injury patients with stroke, they're impulsive. They just jump up, and they can be very irritable. Communication, common language deficits include disorganized oral or written communication, imprecise language, meaning they can't formulate the right words or they're using the wrong word. Disinhibited and socially inappropriate language. Like I told you, the guy that I remember, he knew every 4 or 5, I don't know how many cuss words there are in the English language, but he knew them all. And he fight or flight. So with dysautonomia, let me turn that back up. With